Dr. Peter McCullough.
Thank you.
Welcome, Peter. So, I don't even know where to start. Let's start with the new article. Yeah. Well, do me a favor. Would you do me, before we do that, would you run through your pedigree on the journals you published in and what you used to edit?
Yeah, I was a former editor-in-chief of Reviews in Cardiovascular Medicine for nearly 2 decades. And then my research focus was the heart and kidneys. So I was the second editor of the journal Cardiorenal Medicine after Dr. James Sowers at University of Missouri. And I authored a textbook chapter in Braunwald's textbook of cardiology, considered the Bible of cardiology, for over 20 years. And I'm coming up on 700 peer-reviewed papers and listings in the National Library of Medicine. The average professor of medicine would have about 25 or so. So I've been very productive. And, part of academic medicine is to contribute back to the field, and through teaching, lecturing, programs like this, but also in the peer-reviewed publication space, which is probably the most rigorous of all the things that we do.
And yet, it seems like, I guess we've had this conversation over the years, but that whole space has become adulterated. It's hard to believe what's happened to our profession. It's been the weirdest, oddest experience in 2019. Let's just get your thoughts before we dig into your more recent article.
What a lot of people don't realize is that publications, the vast majority of peer-reviewed publications, come from physicians at major academic centers and medical schools. Those centers have publication policies and approval processes. So once we got into the pandemic and there were new rules that were followed for the pandemic, particularly the vaccines, if someone at a medical school, for instance, had a paper questioning the safety of the vaccines, it would never get approved for that to go out the door to publication. So what we've seen is a heavily biased literature, analyses and conclusions where in general, the author sprinkles this in several times, saying that the benefits of vaccination outweigh the risks. And then they go on to describe a problem. So we have a very biased literature not giving us really a fair balance on this issue.
Yeah, it feels like I didn't realize there was that layer. I thought it was the editorial choices made by the major journals, which also seem to go only one direction. I get it. If you're someone who's read the literature 40 years like I have, you're used to the back and forth of positive and negative results, and sort of a consensus develops, and you can kind of see where it's going. It's never one way. It's just one thing. It's just never that way.
No, it's not. And if you were to pick up New England Journal of Medicine, JAMA or Lancet, there's not a single paper that really questions the vaccines. You're right, it's one way. But if you picked statins, or you picked the back surgery, or antidepressants, you'd get some sense of balance. And I did a Twitter poll, Dr. Drew. You'd be proud of me. I asked a question: would you trust a manuscript that came from vaccinated authors at an institution that mandated the vaccines on the workers and potentially, the patients and others? Would you trust that, or would you be suspicious of bias? And the answer was 98-2. People are suspicious that these papers now are not trustworthy, because how in the world could a doctor who took the vaccines, advised their patients to take it, had their families take it, their institutions mandated, suddenly reverse course and say, wait a minute, there's a question here?
Well, it's the mandate part that creates the liability, it seems to me. I mean, as someone who used the vaccine, recommended, worked with my patients on it, I would have in fact, I have changed course. The further boosting, I'm saying no. And, it's just part of the evolution there. Where I was working on something the other day where I was thinking to myself, wow, we have changed how we manage these problems. I can't think of what it is now, but the changes that happen relatively rapidly as information comes in, both clinically and through the medical literature. But clinical judgment has been expunged from the equation, which is the most horrific idea ever. Usually the medical literature follows physician experience. Usually we kind of know what's going on, and then, and if we have a sense of what's going on, we look to the literature to confirm it or refute it. And if it categorically refutes it, of course we will change our opinion. But if it just seems to go the wrong direction as compared with our clinical experience, we just keep watching. We don't necessarily change what we're doing because, that's gone now. The electronic medical record and the centralization of authority in medicine, there's overlords telling you what to do. Clinical judgment, I wonder how people are going to develop clinical judgment.
There's certainly great concern that, in medicine is both an art and a science. And with the pandemic, the rapidly emerging threat and information, initially it was really all about the art, who had the best feel of things, because the data followed. I'm the only public figure who questioned the vaccines before they came out in writing. I published an op-ed in the Hill. Scott Atlas and I were asked to write op-eds in the Hill the first year. And I wrote an op-ed in August of 2020, and the title of it was "The Great Gamble of the COVID-19 Vaccine Development Program." And when you look back and say, listen, who else actually really questioned that? I have that as a marker, and I questioned it because the vaccines were new genetic technology. We didn't know really what they were going to do in the body, and they were coding for the dangerous part of the virus, the SARS-CoV-2 spike protein.
Right. That's the part that bugs me. So let me just, again, back to clinical experience. I've been using the RSV vaccine on my elderly patients where RSV confers significant risks. It was worth the risk of the platform, in my humble opinion. You could, of course, each physician can make their own decision like that because there should be no mandates. There should be a decision between a patient and a doctor. But in my case, I've been recommending the RSV vaccine. I have seen 0 side effects from that particular vaccine. I cannot say that about the mRNA vaccine that's producing the spike protein. I really think this spike protein is a profound problem. And so let's kind of break down the history. So we know that this platform of the mRNA directed at the spike protein was ready to hand. For some reason, they had a ready to hand spike protein directed mRNA platform that was really ready to go, that they refined and put out to market. Okay, it was an emergency. I get it. How they knew that particular spike protein was going to be an issue. I've just got questions, but okay. Somebody was doing something with gain of function clearly, but okay. Then now we roll it out, and it was, I think, helpful at the beginning. And now we're way down the line here. And what's clear is the spike is the problem. The spike is pathogenic. There are better immune responses to other proteins that virus presents, like the nucleocapsid protein, where if you get a vaccine against the nucleocapsid, and by the way, natural immunity, high levels of nucleocapsid protein is associated with more rigorous immunity sustained over time. Why are we continuing to demand that people go and use the spike protein brand and not looking at other things like Covaxin or whole virus vaccines? If we really want to get into other things, why this one platform, uber alles?
Yeah, there was a paper published in British Medical Journal by Lalani, and the first author. And what I try to do on interviews, if you notice, I will try to anchor it with the first author, and I found that to be very useful. Yeah, I just testified in Congress on Friday, and I mentioned that.
I saw that. Congratulations.
I mentioned that to the panel, and I said, I bet Anthony Fauci didn't cite a single paper. And they just looked at me and shook their heads. No, he could not cite a single source of evidence. But Lalani published that messenger RNA research started in 1985 in the United States. The United States government has poured billions of dollars in this. So have other Western countries. It's really been a darling in the biotech space for a very long time. There's a paper by Lee and colleagues summarizing over 9,000 patents on messenger RNA. The big patent holders, most of the individuals are in Europe, and they work for these big companies like Sanofi and CureVac, BioNTech. Actually, the fourth biggest patent holder is the U.S. government. So in 2012, our DARPA, our research unit of the military, had a program called the ADEPT-3 pre-program. It's still on their website today. It says, we will end pandemics in 60 days using messenger RNA vaccine. So I can tell you that the idea didn't start with Operation Warp Speed. It started a long time because governments have had a love affair with this. The idea of having a genetic code that the body could take and then produce really any protein that one wanted to make is very attractive from a biotech perspective.
Yeah, and I understand why they initially had the spike protein ready to hand, but why they can't switch direction and look at whole virus or nucleocapsid or other things. It's very concerning, especially when we are increasingly clear that the spike is the source of so much of the pathology, both in the brain and in the heart and in the vascular system. And in the ovaries. There's more and more stuff coming in. So you've co-authored an article recently. Tell me about what you discovered.
I assisted Anthony Karagokoulos, who is a physician in Greece, became aware of a case of a man who it was in a kind of lower socioeconomic status, had limited healthcare access, but he did take a COVID-19 vaccine, and within 4 days developed facial pain, and the synopsis of the case is he developed a basaloid tumor that was invasive in both the facial and trigeminal nerves. He originally had a Bell's palsy, but it was very aggressive tumor. It went right into his face, his maxillary area.
So I want to slow down and really be careful with our terms. You say there's a picture of the poor gentleman with his presentation. Also, would you put the scan up too, Caleb? Because that's what that scan was of the tumor itself hitting into the sensory and motor nerve of the face, the fifth and seventh, the cranial nerves.
Right.
There we go.
Is that this
those articles are, yes. Yeah. And the arrows are pointing towards the tumor there. I don't know if people are used to reading that, but we can see that's a pretty large tumor for that area, especially days after a presentation with paralysis. So basaloid, that's the first question I want to sort of define. Is it basaloid in the sense that it looks like its source is the basal layer of the skin, but that it's so anaplastic, it's so aggressive that you can't really identify it as a basal cell tumor?
Well, in this case, that question was asked on the histopathology. It's not connected to the basal layer of the skin. And in this region, a likely source of this was actually the salivary gland.
So basaloid, I'm not used to that term. It just happens to look like a basal cell? Go ahead.
Yeah. So it has features of this, but it's been described. Listen, it can come out of salivary glands. It can come just out of the subcutis, the layer of tissue deep beneath the skin. It's it's come out of adnexal tumors in the pelvic region. So it's a cell type.
Okay.
But the point is, 4 days after the shot, he starts to have symptoms.
It's odd, right? And it makes you like any of these symptoms, it makes you go, I wonder, right? And it's interesting to me, though, that I've seen a marked uptick in cranial nerve palsy, in particularly facial nerve, in Bell's palsy, and myself, and I mean, and how can you miss it? I mean, Justin Bieber had it, and he blamed it on Ramsay Hunt without a rash. No rash from zoster, from shingles. And the doctor just said, it must be Ramsay Hunt. It's like, wait a minute. When that happened, I was like, wait a minute. I've seen so much Bell's palsy lately. Why aren't we?
Wait, didn't his wife get it too?
No, she had a patent foramen ovale and had a stroke, tiny little stroke. It's a very different thing. I mean, whether there's some coagulation issue there and why it showed up when it did, I don't know. But patent foramen ovale is a different thing. But he had clearly just a Bell's palsy that was painful. That's all, which is not uncommon for Bell's palsy to be painful, not in my experience. So it's just, isn't it interesting that area is sort of in the mix here? Did you make anything of that?
Yeah, well, no, I agree. Let's just, for our listeners, distinguish Ramsay Hunt from Bell's palsy. So Bell's palsy is the seventh of the facial nerve, but it's away from the ear. And so it paralyzes the face, as you can see in this picture of this man. You lose the the crinkles of the forehead.
Justin Bieber in this case.
Now Ramsay Hunt has a telltale rash actually in the ear, and it's actually the rash of the reactivation of varicella zoster. Ramsay Hunt has pain in the ear, and about 50% of the time, it actually involves the auditory nerve as well. So it's not just the seventh nerve; it's actually the nerve that is hearing. So there's a problem with hearing and pain. And so the interesting thing with Ramsay Hunt, though, is when it spontaneously occurs in older people, who have not taken the chickenpox vaccine, about 90% resolve with treatment. And we, use just a simple combination of drugs. So Ramsay Hunt ought to resolve, and about 10% are permanent. Bieber's now, I think, 2 years into not touring, and I presume his face is not back. Ramsay Hunt has been described after COVID-19 vaccination, but as you point out, Bell's palsy far more common as a facial nerve abnormality.
And no rash. One of his interviews, he went, "Oh, they didn't see a rash, but they still say." Look, I'm going to tell you for sure. I deal with a lot of Bell's palsy, and it's very common for it to be painful, particularly at the outset. It's just very common. I don't know why, but it's a common thing. And I've seen other things ringing in the ear and stuff like that. Remember, the seventh nerve goes through there, and so they call it Ramsay Hunt anyway. But the point is, that is one of the things that has been, for sure, has been associated with the vaccine. Now, the other thing I want to define thoroughly is this term that's flying around. By the way, there's a lot of craziness out there these days. I mean, people are going berserko on all sides. So I want to make sure we are really careful in defining our terms and what we're talking about. This term turbo cancer, which is a term that has shown up lately. What do you imagine people mean when they talk about turbo cancer?
I think people are thinking of rapidly progressive cancer or a reactivation of a cancer that was in remission.
Okay. So it's a made-up term. I wondered if they were talking about the fact that people seem to be, and I've not seen this documented, that oncologists were I'd heard them saying that young people in particular, by young we're talking about under 60, when they presented to the oncologist, they tended to have more advanced disease. In other words, stage 3, stage 4, as opposed to earlier, okay? And so the speculation was a more aggressive tumor, which is why they were showing up with more advanced disease. That still needs to be documented if that's true, right? There's sort of hints of it here and there, but it's not been well documented. And my fear is they're not looking into it because they're fearful of what they're going to find. What do you think? Yeah.
And to be fair, there's this idea of detection bias too. So, through the pandemic, people got behind on mammograms and colonoscopies and things of this nature. And remember, these are things that are not done with an intense frequency. So someone, literally could just be 2 years off on a colonoscopy and then be behind on a colon cancer. I saw a patient today who had colon cancer.
Absolutely.
So that's part of it. The point of this case, though, and I wanted to emphasize this, is that he started to have symptoms within 4 days. Now, I can tell you any mechanism of cancer, it just doesn't happen in 4 days. So what we were almost certainly dealing with is that the cancer was there already, maybe arising from the parotid gland. And the vaccine and the inflammation associated with the vaccine and its predilection for the facial nerve area, trigeminal nerve, it allowed detection of the cancer, and then all the eyes were on it. Do you see what I mean?
So there's incredible. Yes.
There's a detection bias. There's a paper actually from my former medical center here in Dallas. The same thing is true for breast cancer. So women would get an injection in the arm. There can be some discomfort, swollen lymph nodes. Then there would be a concern potentially. And then there's a drive to investigate breast cancer. And so if it is there, it's more likely to be detected. So part of this is actually what we call detection bias.
Which is not a bad thing. That's okay. Well, I'll take it, right? I mean, the problem is, though, and I think the question you're bringing up is whether or not the immunological shifts associated with vaccination are somehow allowing this to grow more rapidly. Is that one of the questions you're asking?
Right.
Yeah.
So there's a paper just is fully peer reviewed now and published. The first author is Anguis. The second author is Bastillo. And there, the title of the paper is The Multi-Hit Hypothesis of Oncogenesis After COVID-19 Vaccination. It's a hypothesis. But in 1984, Sutherland and Baylor published the multi-hit hypothesis of cancer, saying, listen, if something causes cancer, it's not going to be by just one mechanism. It's usually multiple mechanism. And how this lays out for the vaccines, particularly the messenger RNA vaccines, is the Chinese have shown that the messenger RNA may impair DNA repair within the cell. And that's a way we can defend against cancer. A paper from University of Pittsburgh by Singh and Singh demonstrated that using modeling, that the S2 segment of the spike protein, which one does get with the vaccine and does not get with the infection, the S2 segment would likely impair the P53 and BRCA or BRCA tumor suppressor system. So we have some natural tumor suppressor systems. The S2 segment may put a drag on those systems. And if there's already a loss of function mutation in one of those systems, one could be at risk for cancer progression. Remember, a BRCA mutation is actually a relative loss of function of the BRCA tumor surveillance system. That's for women, breast and female reproductive cancers. The third and final mechanism is what Dr. Joe Ladapo, Surgeon General of Florida, has brought up, is what's called DNA process-related impurities in both Pfizer and Moderna. It has not been shown in Janssen or the other vaccines. And what I mean by that is E. coli is used with a genetic code in a circular piece of DNA called a plasmid, and the E. coli multiply rapidly, so that plasmid has the code for Pfizer Moderna, but it also has an antibiotic resistance code, a gene in there, and then something called SV40 or simian virus 40, which has a promoter, an enhancer, and what's called an origin of insertion. SV40 fragments are for sure been identified in Pfizer and Moderna. These are known activators of proto-oncogenes. And what Ladapo pointed out to the CDC and FDA is said, listen, unlike messenger RNA, DNA actually gets into cells very readily. Naked DNA does. Yeah. And if these are taken up, if someone has a proto-oncogene, it's theoretically possible that through this mechanism, we could have the initiation of cancer.
So I've got a bunch of things I want to get to before we go to break, but one is, what was the name of that biologist from South Carolina who brought this up, was one of the first to sort of present it to his state legislature, and he was doing research on it, and then he just disappeared. It was really odd to me. He just was raising the question. He was like, this is not, I've detected it, it's not good, there's all sorts of concerns. Do you know what happened to him?
No, he's been pretty quiet. He testifies. Dr. Buckhalter, he testified in the Carolina Senate. But remember, David Spiegler from Canada has found it, Kevin McKernan, molecular biologist, and a Dr., I believe, Koenig in Germany. So we have 4 separate labs. Now there are tolerances. By the way, the FDA has guidance on this. There's tolerances in terms of the quantity of these DNA fragments and the size of the fragments. And some of the samples exceed these arbitrary tolerances. And then in the Spiegler paper, it's the ratio of these fragments to the messenger RNA dose that's related to adverse events. And that's the real concerning thing here, is that, at least one study shows it's related to safety. And when Ladapo wrote the FDA, he said, listen, I want to hear your response. The FDA didn't volunteer to do an inspection, to look into it. They basically brushed him off. And that's when he said, that's enough. That's the straw that broke the camel's back. I'm going to call for them to be removed.
And Joe is somebody I know. He's a very bright man, an excellent doctor. He's just raising questions. We all just want to get it right. That we may have differing ideas. We may have stronger opinions on one side of this or another. We're all trying to get this right. That's all, trying to get it right. And in order to do so, you must ask questions. That's the way it works. And this has all been such a astonishing experience. Okay, so I want to just swing back around before the break here. And Dr. Latipo is going to be on the show on January 31st. He'll be back in a couple weeks, or less than a couple weeks. The DNA repair mechanisms. Caleb, I'm going to ask you something terribly unfair, and you may not be able to deliver on this, but there are a ton of videos out there on DNA repair, just the mechanism of DNA repair, little cartoons about how it works. Your DNA replicates, it produces proteins, but it also replicates. That's how cells divide. And when it replicates, it makes mistakes. It's spectacularly complicated replicating DNA, and they have a whole set of machinery that run by and do the repairs. You can have deficiencies in those systems. BRCA is one of those. I think most people have heard of BRCA1 and BRCA2 of breast cancer. I have something called Lynch syndrome, Dr. McCullough, and there are 6 different types of Lynch, if I remember right. And Lynch is a genetic, my sons have it. It puts me at risk for colon cancers or GI cancers and prostate cancer, which I have. And if you add something else to make that DNA repair mechanism less efficient or another hit of the DNA repair mechanism, I'm in big trouble. So these are not simple concerns. These are legitimate questions and Lynch is not that uncommon, nor is BRCA that uncommon, nor are 30 other of the more common DNA repair abnormalities and another couple hundred unusual ones. These are common things in the human biology. And so if we impair that further, it's just a terrible thing to even have to think about, and yet no one will ask the questions about it except you.
Well, it was probably about a year or two ago. There was a wonderful image demonstrating the spike protein. Now, remember, we get the spike protein from the infection as well as the vaccine. It was basically, inside cells. A lot of people don't realize this. Most of the spike protein is inside cells, and it's attached to red blood cells. But it was inside cells, basically right on the nucleus. So if the University of Pittsburgh paper is right, these DNA repair mechanisms, could be impaired by spike protein, almost certainly by the messenger RNA. But products like messenger RNA, Pfizer and Moderna, they fall under the genetic transfer technology regulatory guidance by the FDA. And I mentioned this at my congressional testimony. This calls for a 5-year window of safety observation and concern. People have asked me, is it over with? They took the shots. I said, no, for genetic products, it's not over with. We've got about a 5-year window. We need to be alert.
Yeah. And again, the thing we're all sort of questioning now is I'm perfectly comfortable with the idea that there was an emergency. They did what they could. It interrupted things. It had some utility for elderly patients for sure, maybe some risk, but in my opinion, worth the risk. But what are we doing now? What are we doing now pushing these things further? And particularly to children and pregnant women. And there have been some data recently that Steve Kirsch was pushing out that was very disturbing. I don't know if it's accurate or not, but I can't rely on the medical literature anymore because it's so adulterated, and it's very hard to know where to go to get good information. So we're going to take a break, and we're going to talk about that. Look, here's the DNA.
I don't know if this is what you're talking about. I'm trying. I think this might show what you're looking for.
Repair.
It's a DNA damage response.
The DNA damage is a little different.
That's different.
The DNA has to. That's different.
Maybe
that's a damage.
About to show
but
it's
the same.
Damage.
It's the same system that comes as damage, right? But
Guys,
it's the same system that comes along and repairs it. No, but Caleb, you're nearly there. It's the same system that comes along and repairs it. So it's just that it happens naturally in the course of it.
Wait, the animation now it's showing something repairing. Maybe is this? Wait,
it's the same system. Yeah, there it is, and it's the same kind of system that's part.
There we go.
And so, yeah, this is a little different. This is going to make a case for a cancer drug, frankly. Yeah, but it's all the same idea. All right, let's take a little break. When we come back, we're going to talk about where we get good information. I want to hear more of your thoughts about the DNA contamination, concerns about that, and then Caleb's going to find us a good video. Be right back after this. Ladies and gentlemen, let's make a resolution that's easy to keep and delivers immediately on its promise. With Genucel Skincare, you can turn back the clock and look 5, 10, even 15 years younger. And right now, Genucel Skincare is celebrating 2024 with its New Year's sales event. Save over 60% off all of our favorite Genucel products with one of our customized skincare routine packages. Say goodbye to those fine lines in the forehead and around your corner of your eyes, sagging jawline, dark marks, skin redness, even under eye bags. Leave them in 2023. Genucel works for women and men. It's safe for all skin types and perfect for skin of any age. Plus, with its immediate effects, Genucel promises results that will make you smile. Guaranteed or 100% of your money back. Start your new year look off right with one of our custom Genucel skincare bundles right now at genucel.com/Drew. Use our special code Drew at checkout for extra savings off your order today. And remember, every order placed is automatically upgraded to free shipping. Don't wait. That is genucel.com/Drew, genucel.com/DREW. Well, most of my career I've been urging people to kick habits, change habits. Well, this time I'd like to suggest getting into the habit of adding Paleo Valley grass-fed bone broth protein to your daily nutrition regimen. Here's CEO Autumn Smith.
It's made from cows with 100% grass-fed and finished, and bones. They're bones rather than the hide. Most bone broth or collagen powders are made from hides or hooves, but ours is actually made from the bone because it'll contain additional nutrients. Bone broth is a way to bring back those nutrients, those minerals, and there's glucosaminoglycans, and then there's collagen, which helps us prevent wrinkles and joint pain and actually heals our gut. There's gelatin, and there's just all of these ingredients that the modern diet has kind of left by the wayside.
Susan and I have been mixing the chocolate-flavored bone broth literally into our coffee every morning for months, and we've noticed a difference in our energy, appearance of our hair, skin, nails. Susan's particularly very happy with this. The bioavailable protein also helps us feel satiated. That's the part I'm happy with. Paleo Valley bone broth also comes in vanilla and pure unflavored and can easily be added to your coffee, smoothies, yogurt. Go to drdrew.com/paleo, P-A-L-E-O, for 15% off your first order. Again, that is drdrew.com/paleo. We all know the value of a good night's sleep. We feel better, look better, have more energy to spare, but you could be missing out on all of those benefits if you're sleeping on sheets that are too hot or too cold or just plain uncomfortable. I have the solution. Cozy Earth bedding. Cozy Earth is the softest and most comfortable sheets, blankets, loungewear, and more. They use premium viscose from highly sustainable bamboo, and we sleep in them regularly. I wear their t-shirts. Susan wears their pajamas. Cozy Earth bedding comes with a 100-night sleep trial, which means you have up to 100 nights to sleep on them, wash them, try them out. If you're not in love, just return them within 100 days for a full refund. Susan and I love them. In fact, we have Cozy Earth sheets on our bed right now, and they made a huge difference in our sleep. If you've never tried Cozy Earth, we have some awesome news. You can save up to 35% off Cozy Earth right now. But hurry, this offer will not last. Go to CozyEarth.com, enter my promo code DREW at checkout for up to 35% off on your first order. That is CozyEarth.com, promo code DREW, COZYEARTH, CozyEarth.com, code DREW. And we are back with Dr. Peter McCullough, whom you know. And before we bring our guest back, Susan yelled something to me during the break. What did you yell at me during the break?
I had the bone broth, chocolate bone broth before the show.
So
no coffee, though, because I haven't been able to sleep at night doing that.
With the coffee.
But we love all our sponsors and want to give them a shout out.
Well, speaking of that, I wanted to talk to Dr. McCullough. Let's bring Dr. McCullough right back about being ready for things as they come. That's why, you and I like working with the wellness. One of the reasons we like with the wellness company, in that they help patients be prepared, get access to things they should freely have access to without a lot of encumbrance. Maybe we should address what readiness looks like.
Yeah, that's a great point. You and I probably can be viewed as being critics or dissidents or what have you. But, from the very beginning, you and I both have been trying to provide solutions, and solutions by improved knowledge. I published the first multi-drug treatment protocol, which incorporated the Operation Warp Speed drugs as they came along, including Paxlovid, Molnupiravir, the monoclonal antibodies. But I was trying to bring people an approach on how to treat COVID. The same thing is detoxification after the vaccines. That's basically a proposal, all published in the peer-reviewed literature. Wellness Company has kits now. They have a medical kit. It's It's an aqua blue color. It's a very broad and diverse medical kit, can handle everything from a urinary tract infection, a fungal infection, a bronchitis, things that will come up with a guide. If there's any questions, people can, via telemedicine, get their questions answered and get on the right track. But it's basically an at-home formulary. Yep. For the first time, people, instead of being held captive by an urgent care or by a doctor's office or an ER, they can actually do this themselves at home.
Right. You can get these right now, not have to worry about reaching a doctor or spending a fortune at an urgent care. And as you have now found out, during a crisis, things can shut down. It can become very difficult, which is why you want to have things ready to hand. And we are going to have more available through TWC too. We've got a lot of interesting things underway that I think are going to be fantastic in terms of empowering patients to do what they need to do. It's relatively people. These things have been around a long time now, so it's simple. People understand these things. They understand how they work. And with a guidebook and backup of telehealth, you can really do a lot on your own without having to interact with an expensive system. You really don't. It's just, that's my 2 cents. So
go to drdrew.com/TWC and check out everything they have. See what jumps out at you.
Oh, it's odd to me that, by the way, Peter, people go, oh, it's a supplement company. It's like, no. Yes, they have excellent supplements. And by the way, Susan and I take several of them. But no, this is going to be, this is the process of something so much more for patients.
It's true. They have One Wellness, which is unlimited telemedicine and supplements. Some, patients who have limited insurance or just have the, catastrophic version of insurance and they have diabetes, hypertension, they just need to, glucose monitoring, drug changes, things of this nature. It's very affordable and can provide a great backstop. I think it's almost essential for people without healthcare insurance in the United States. A lot of self-employed contractors and others are still in this. They fall in that gap. One Wellness or just membership in the wellness company, getting that access to doctors is key. They also have a great medical education, the nutraceuticals and supplements, telemedicine. Will have actually their first brick and mortar clinic, a dental division. It's really an alternative healthcare approach that people can, have as a supplemental. Some use it, mainline. The company's done a great job. It's been now around for about 1.5 years and steadily growing.
Yeah, I'm delighted. Been delighted to be a part of it. And if the supplement world is kind of interesting. If those of you who watched yesterday, we talked to a neurologist he was a geneticist and did a lot of work in Alzheimer's, and he was was he a cardiologist? I forget what his underlying training was, but he was talking about lithium orotate for protection. Some of his Alzheimer's research suggested that lithium orotate may protect against a bunch of influences on particularly the hippocampus. So Susan and I started that today, and I want to get the wellness company into that. So
Thank
that's
God
how these
for
things
Amazon.com,
happen. That's how these things happen. So let's go back to where to find literature that we can trust. Where do professionals go even? Let's start with that. Forget the average person who must be just terribly confused. How do professionals navigate the literature these days?
Well, we have the National Library of Medicine PubMed, PubMed. So that is the historical search engine for basically everything from the beginning of peer-reviewed publications. It goes back a considerable distance. So if you typed in any subject and you typed in review, it would bring in basically a summary paper on a disease topic. So for instance, in preparing for this interview, I reviewed Ramsay Hunt and Bell's palsy. I assumed you were going to ask me. I reviewed the source of basaloid tumors. That's all through PubMed. Professionals can do that. There's other sources out there, Cleveland Clinic, Mayo Clinic. They try to provide resources. There is Up to Date. That's another commonly used resource by physicians.
Up to Date to me feels like it's just collated materials from what's the major journals are publishing. But Mayo, I agree. Mayo is an excellent source for people. And then let's talk about and some of the other PubMed, of course, these other things you mentioned. But in terms of institutions, you can't go wrong with Mayo. Talk about the DNA contamination. What are your concerns about that? We sort of laid out what the biology is and what the issues are in terms of regulatory tolerance. What do you worry about with this?
My single greatest concern is that the US FDA and the manufacturers will not do inspections or issue independent inspections. Tylenol gets inspected, consumer products, foods that we eat get inspected. We're 3 years into the vaccine campaign, and we don't see inspections for things regarding concerns. And the concerns are the quantity of messenger RNA per vial, because we know the safety events vary according to batch. And now these DNA process-related impurities. I did see inspections by the FDA in 2022. I did see them. They came through a Freedom of Information Act. And for instance, Moderna, by the way, the companies don't make their own vaccines. They subcontract this out. So for Moderna, it was Catalent. The company Catalent does the final fill and finish. There was an FDA inspection, but it was only for visible impurities. They literally just looked at the vials and told Moderna, we see precipitate in the bottom of the vials. There was nothing complex about these inspections. There's enough concern that our FDA should issue broad inspections. They are returning many, many vials because people aren't using them. So there's plenty of vaccine available to study to see if there's a quality assurance problem.
Well, I remember talking to, was it Sasha Latipova? Caleb, help me out. I think that she was one that raised questions about the way the manufacturing was done in terms of the batch size and whatnot. And then we had I believe she was Danish physician that ran that article that showed that early in the pandemic, early in the vaccine distribution, 90% of the adverse events were accounted for on the basis of 10% of the vials on a small batch of vials. And it took her 2 years to get that published. They wouldn't publish it. That's insanity. And so now this is sort of the next layer of that, whereas they refused to do the review of the process that they are charged with doing. Let me do something. Caleb, throw up my survey that I put out yesterday. I just put up a quick survey. Again, Steve Kirsch was all over me yesterday. Please put the survey up. So I did it. And when I say asking for a friend, I was quite serious about that. It was for Steve Kirsch. And I got 63,000 responses. It was a simple question. It didn't parse out what kind of reactions people got. It was, did you or someone in your household have an injury from the COVID vaccine? Yes or no. And the third category was no one took it. And Peter, I'm sure you can see this. So that 22% seems a little high to me in terms of vaccine resistance. But 17% of 60,000 people had something they called an adverse reaction or an injury from the vaccine. And it's odd to me. It's really interesting. And many of us had vaccine injuries and don't even think about it. I had a vaccine injury and I had a terrible reaction to the vaccine with a sudden, a raccoon eye developing and all kinds of things. And I never put myself, there's my eye. I never put myself in the vaccine injured category because it just passed and I was okay in the long run. But it's true, I was vaccine injured. And when you ask the question, you get 17%. That means around 20,000 people in that simple sample had something they considered to be a vaccine injury. If it had been 1% in days of yore, meaning prior to 2019, that would have had a vaccine pulled or at least examined very carefully. And instead, when I got a lot of Twitter, there were a lot of people reporting horrible things, which was sad to see. And then the other side was people saying somebody adulterated this survey. It's not that high. But 1%, would you agree? Even 1% 5 years ago would have been enough to get a vaccine, at least pulled temporarily.
Right. I mean, American College of Cardiology, for instance, different topic, but considers low, moderate, and high, let's say for side effects with a surgery. Low is less than 1%, moderate is 1 to 5%, and high is more than 5%. But, high risk for a complication is more than 5%. Let's just take that as a working axiom. We know that the CDC vSafe data, which was the cell phone application that people voluntarily could do to tell them, reminds them to take a vaccine, and they report their side effects. 7.7% of people in the vSafe system, over 10 million Americans, got so sick with the vaccines, they went to urgent care, the ER, or were hospitalized. 7.7%. The Danish paper you cited by Schmeling and colleagues, the number was about 4.2% of vials was accounting for the side effects. And then the NeuroCovax study from Italy, 17,000 people, it's about 30% that had some neurologic side effect. There was a Zogby survey in the summer of 2022. They settled at about 15% were reporting some problem. So let's take it at face value. It could be, serious things in 5%, maybe as much as 15% with side effects. I mean, this is a very toxic vaccine. This is one that people are going to remember for a long time.
And so the pushback I'm hearing is, well, COVID would have worse data, okay, which may or may not be true. There is a third category, which is COVID plus vaccine, maybe the culprit even, I don't even know. How do we sort these three categories out? I've been asking for it for 2 years, and no one has done anything, certainly not prospective, but I can't see anything that really sorts that out. Could it be is the COVID that really answers the question? There's lots of anecdotal stuff and people have opinions about it, but I've not seen one solid study that really teases these three categories out.
Well, there's 3 early papers, Raw, Kramer, Mathidius. They all showed that if one had COVID first, then they took the vaccine, the side effects were much higher. So that was known very early on. In fact, when those papers came in, I said, boy, it is really going to be ill-advised to tell somebody who recovered from COVID to go ahead and take a vaccine. So in 2020...
What was that published in? I'm sorry, Peter. I got to pull that article. What were the names again? Caleb, maybe pull it.
3 authors, separate papers. Raw, R-A-W. The next one, I believe, is Kramer, C-A-R-A-M-M-E-R. And the last one is Mathidius, M-A-T-H-O-U.
We'll find that.
Yeah, you can find them actually on America Out Loud News. I summarized those early on. So those were key papers. So the question is, in 2020, who got COVID? Now, I know I did. And there's a paper by Daniels and colleagues, very important paper. It was from the NCAA Big Ten Athletic League. And, they were actually looking for myocarditis in 2020, looking for it. And so any athlete who got COVID, they did multiple blood tests and EKGs and cardiac MRIs, thousands and thousands of individuals. Now, they came up with about 36 putative cases with some abnormalities, nothing adjudicated, no hospitalizations, no deaths. So we knew from that paper that community COVID was not causing significant myocarditis. But in that paper, the answer was 30% of the athletes and the students got COVID in 2020, when you actually look for it. So I got to tell you, a significant number of young people already had COVID in 2020 before the vaccines. Then the vaccines roll out, and the papers predicted, wait a minute, if you already had it and you start taking the vaccine anyway, you're going to have more complications. So we have that as a baseline. And then a paper from Germany appeared this year, Dijkstra and colleagues, the first author, 48,000 Germans, and it's looking at long COVID. The conclusion was, if you had taken a vaccine, long COVID is way worse, not better, way worse. The people who end up the best are those who never took the vaccine and their first episode of COVID is Omicron.
Oh, that makes sense. That makes perfect sense to me, because the durability of immunity to the actual virus and the multiple antibody responses to the various proteins that the virus presents clearly have an advantage, clearly last longer, clearly are more durable in most cases, not in all cases, but in most cases. That's very interesting. Gosh, there was something else ringing in my head that because my hippocampus has been shrunk by COVID and the vaccine, I can't remember what I was going to say.
Maybe it's that new supplement.
Shoot.
But let me just add to that, the natural immunity was so impressive. There's a paper by Chin and colleagues, New England Journal of Medicine, October 2022. U.S. prison system, this is a great study, 59,000 prisoners, 17,000 staff. Once somebody had been through the Delta or Omicron variant, and they got another infection later on with another Omicron, zero risk of hospitalization and death. Zero.
Right. I've seen data like that. Yep. I've seen data like that.
So here's
that keeps
the point.
coming around.
Right. So the point is, prisoners are highly motivated to be hospitalized. They want to break from prison. I know this. I've taken care of prisoners before, and they just couldn't get sick seriously a second time. So when people call me with COVID, and I do have patients with COVID, the first question I ask them is, have you had a well-documented case before? That's the most important question now in risk stratification.
It just makes you shake your head. And yet the continued extreme pressure for babies and children and young adults and pregnant women, it's just, I get it for the older population that, again, it's a risk reward that's a totally different diathesis than a 22-year-old male. But the continued push, what happened at the CDC? Is it just that the people in the higher positions of authority really aren't great clinicians? They're just bureaucrats who are just political appointees pushing agendas, or I don't get it. It's mystifying to me.
One theory is, unfortunately, it's a sociological theory, but that widespread corruption is set in. Rand Paul sent a letter to Rochelle Lewinsky, who was in charge of the CDC at the time, that Pfizer and Moderna had an installed marketing unit in the vaccine center, Weber Shandwick. So I was always wondering, why does the CDC push messenger RNA as opposed to adenoviral DNA or the antigen Novavax?
I still wonder that.
Right. So the marketing, he said, listen, you can't do that. It turns out CDC was paying Weber Shandwick about $50 million for their marketing efforts. So you have that going on. Robert Califf, who's the commissioner of the FDA, somebody who I know personally for a long time in cardiology, he's out there actually promoting vaccines. Now, we can't have an FDA commissioner promote vaccines. The FDA has to be unbiased. They have to be a watchdog on safety. Now, he's out there tweeting, promoting the vaccines. The FDA cannot be an extension now of the pharmaceutical industry. We've lost our regulatory compass here.
I know what I was going to comment on. You were talking about long COVID not being reduced by vaccination. There was a good study out recently that shows the same thing from Paxlovid, that it does not increase or decrease the potential for long COVID, and that fits my clinical experience. It can sometimes really rapidly resolve the acute infection. There is rebound, period. It's well documented in some cases. And there is no reduction in long COVID. So it's an interesting medication that I don't think we have anything like that for molnupiravir. So Peter, what happened to white lung? What got? Oh my God! White lung. White lung was coming. There's going to be. Oh wait a minute! It's monkeypox. No wait a minute! It's disease X. Oh, they keep trying to throw. They are just addicted to hysteria. Is really what it is. They are absolutely addicted to hysteria. I don't know why. It must feel good to people to be hysterical. Don't worry, you can get hysterical about politicians and other things. There's plenty to be hysterical about, everybody. You don't have to come into our domain. I guess it's time to talk a little more about disease X. What do you understand about what was going on there, where that came from, what the risks that poses us?
Vaccine developers have been talking about disease X for years. Peter Daszak at the EcoHealth Alliance, who had a hand actually in the Wuhan Institute of Virology and with the NIH, and Ralph Barrick in the whole origins of SARS-CoV-2. He wrote a piece, I believe, in the New York Times in 2018 on disease X. Disease X is not a real disease. It's a concept of, can scientists use gain-of-function research and make a serious disease in the lab and then make a vaccine to it? So it's a strategy. And what Daszak says is we want to get ahead of nature, try to anticipate what nature is going to potentially evolve, and then create this new pathogen in the lab and have the vaccine ready to go. Today, the World Economic Forum actually has a whole session on this about disease X. And what people are really worried about, and by the way, none of these sessions have anything on it about improved biolab safety. What people are worried about is creation of all these pathogens in these labs and then having another security breach, and then we're off to getting the world sick again.
And the disease X that has hit the headlines lately is as I understand it, if I remember correctly, a modified coronavirus that affects brains and was shown to kill mice quickly. Is that what I'm hearing? This particular disease X of hand lately?
Well, yeah, it was a modification of a coronavirus. And again, back to Peter Daszak, the EcoHealth Alliance employs dozens and dozens of scientists. They're funded by the U.S. government. He's just been funded again. He's not taking the research projects to Wuhan, but he's going to Duke University in Singapore to work on bat coronaviruses, to actually do more coronavirus research. And we know that gain-of-function research is done outside the United States. It's not banned in the United States. It's just the federal funding for U.S. institutions is banned. So there's foundation work and independently funded gain-of-function in the United States, and then it's a gain-of-function bonanza outside the United States. And I think, if anything, our world leaders ought to look at gain-of-function research and really ask a question: is this wise to do? We've already gotten the world sick once with this. Is this going to be a repeated problem?
Yes, I agree with you. I want to restate it and state it out loud, which is that somebody, ideally in positions of authority, need to examine this systematically in a large setting with lots of smart people. I don't want to throw the baby out with the bathwater. On one side, people are saying it's a crime against humanity that we are doing this kind of gain-of-function research. On the other, they believe they are actually helping people prevent these pandemics of the future or be able to respond to them. I'm wondering if there's a middle ground. I wonder I don't know that a crime against humanity. The folks that say that, I would want to see some motivation that people are actually trying to hurt people. I don't think people are trying to hurt people. I think they have a point of view. They're forging ahead. There's all kinds of secondary gains that they get. They believe they're doing good. I just don't know if it is worth the risk. Wouldn't you agree, Dr. McCullough?
We don't hear about nuclear warheads and missile defense systems anymore. The new normal now is these biolabs, biological threats, and then countermeasures. Countermeasures are vaccines, monoclonal antibodies, and therapeutics. And this is the new normal. It's a very rich environment now. In our book, we define this biopharmaceutical complex. It's this syndicate of these NGOs, richly funded, Gates Foundation, Rockefeller Foundation, Wellcome Trust, the WHO. They're not elected organizations. They're NGOs. They're funding each other. You have the pharmaceutical companies closely tied to them. And the investments are very rich. Remember, if there's another pandemic, the government is buying all the products, prepaid. Can you imagine? A blockbuster drug used to earn $1 billion in its first year, and the companies would spend $500 million or more in research and development. Now the vaccines, the new normal, is $100 billion, and the government pays for the research and development. The question marks over my head is why monoclonal antibodies weren't pushed more, or why people weren't educated about monoclonal antibodies. And to that same point, when I went out and I did a bunch of Instagram lives when I was sick, and I tried to tell people about, I had a marked response to monoclonal antibody back when it was bamlanivimab. And I was saying we should be educating people how to respond to COVID, not how to hide from it, how to get well. It was something I know you were very involved with. Mm-hmm. And the first pushback I got was, "Oh, you can afford it." It's like, no, it was free.
The government had already bought all the monoclonal antibodies, and they will send somebody to your home to do the infusion. The government pays for it. And was it that it was too expensive? The government was fearful of incurring all that expense, but it was the oddest thing in the world to me. And I understand we had to come up with new monoclonal antibodies as the virus became more responsive, less responsive to them. But why do you think why public health didn't educate about public health? What was going on through all that?
It was an epic failure. I used the monoclonal antibodies probably hundreds of times and consistently safe and effective, pulled people out of it. And it's a paper in Medical Economics in 2020. They were all pre-purchased. We had enough monoclonal antibodies to treat every American. And what the FDA did is based on modeling, not based on clinical outcomes, but modeling, they quickly pulled each one off the market, saying, the virus changed. This monoclonal antibody can't possibly work. We don't know if they're right or they're wrong. But when the analyses have done retrospectively, they had a massive decrement in mortality. And the shortcomings were, I had a patient today who got really sick with COVID in 2021. This is a diabetic, obese. He's had strokes, and he goes in and he wants monoclonal antibodies. And they said, your O2 saturation is just too low to get them. And it was modest. Maybe it was, What does that even mean?
Was he in heart failure and they couldn't handle the extra fluid? What is going on here?
There were protocols saying if the O2 saturation was low, or if the patient was going to be an inpatient, they couldn't get it. And those are the exact people who needed them. So I made the case, Dr. Drew,
yes.
I made the case that every patient in the ER who was sick enough to go to the ER should have gotten a monoclonal antibody infusion. And there's a paper written on this. It was about 15% of people actually did get the monoclonal antibodies. Once they were admitted, they almost all survived. It's those who didn't get the monoclonal antibodies who passed away.
It could have been used as a preventative if there was somebody at high risk in the home with somebody with COVID. It could have been it could have taken care of everything, but we were in such a weird hysteria that, and I remember, if you remember, this one of the most disturbing chapters of many bad chapters was the governor of Florida was doing exactly what we're talking about. I believe it was when there was a dual agent monoclonal antibody and had vans and was going out and distributing it throughout the communities. And the government pulled the monoclonal antibodies from the state of Florida.
Right. Yeah, when you think about it,
that was criminal action as far as I'm concerned. Now they claimed they had to distribute them elsewhere. I want evidence of that. That looked criminal to me.
Mm-hmm. Yeah, no, I agree. When you think of it, if I was running the operations, I would have had all the nursing homes with a monoclonal antibody infusion program. Either stock them or rapidly deliver them. The home infusions were great. All the ER patients should have gotten them. They were always safe and effective. There's actually not been a single analysis showing that they failed in any way. And we're talking about outcomes of hospitalization and death. The monoclonal antibodies were a winner. And there was even this dual combination that could be given as a depot intramuscularly. And they provided protection for about 6 months. That could have protected our immunocompromised and transplant populations. It just was a travesty that they weren't leveraged.
So again, I want to, this stuff goes by pretty fast. I want to make sure we make note of some of this stuff. There was several studies on an oil-based dual agent that was used to prevent COVID in people who are high risk and were even exposed in the household. Now, as I recall those studies, it was not 100% effective, but it significantly reduced transmission in the home for people at high risk.
Yeah, for sure. So, and I use them in my practice. Yeah.
Oh, no kidding. It therapeutically or as a prophylaxis or both?
As a prophylaxis, it can be used in a dialysis patient, and you can get it every 6 months, and it provided wonderful protection. Even if they got it, it was very mild. So the point we're making, Dr. Drew, is not everything from Operation Warp Speed was bad. That wasn't the case. It's just that our public health response couldn't sift through this and get things operationalized, and people suffered.
Well, you're being kind in sort of saying it that way. They had 2 or 3 messages, and they couldn't get off them, and they were the only messages, and anything else that could have helped people and save lives, if you were literally crushed if you brought them up. It's just, there was so many misadventures as this thing rolled along, and my fear is that there are continuing to be. And certainly, if our history is any lesson, it's worthy of contemplating that there could be things afoot because they've made huge mistakes in the past. Let's just try to get this right. That's all we're all trying to do. We're trying to get this right. Dr. McCullough, going forward, are there things you have concerns about? And then we'll kind of wrap this thing up.
The greatest concern is that, I just testified in Congress. We had some frank conversations. It was the opinion of Senator Ron Johnson and even others on the congressional side that we don't have enough public will, believe it or not, to pull the vaccines off the market. We certainly don't have the will in Congress. The FDA is not going to do it. There are 5 congressional oversight panels over the FDA. They have very loose and powerless oversight, but they can't even muster up the impetus to actually write a letter, calling for the vaccines to be pulled off the market. We've got one Surgeon General. We have dozens of them across the country. That day, Friday, January 12th, a Rasmussen poll came out. 53% of Americans do think the vaccines are having serious side effects leading to large numbers of deaths. 53%. But that means 47% don't. So the conclusion was we do need more public awareness that these are going to continue to roll. We can't rely on the FDA to safeguard Americans.
And there we are. Whatever your concerns are, whichever side of the argument you land, our job is to make the best decision for each patient that sits in front of us. That's it. To use our best judgment, that's it. That's our job. And no one from on high should be determining what we recommend, but it is important that we all carefully read the literature, carefully try to assess the science, and assess the risk-reward for the given patient in front of us. Dr. McCullough, it's always a privilege to talk to you, and it's always a pleasure to serve with you on the board at the Wellness Company, and I'll see you on Friday morning.
See you then.
All right, Dr. Peter McCullough, everybody. Get him at petermcculloughmd.com, McCulloughMD.com. Caleb, did you ever get me that video on DNA repair? I didn't want to necessarily
I tried to
push
find it. I found some, and then I thought the show was ending, and I closed all my tabs, so it's gone now.
Okay. Khan Academy had some good. If anybody wants to see it, Khan Academy has a good one. Just put DNA repair replication, DNA repair in replication. So again, DNA replicates itself. When you have two complete strands of DNA, but there are errors in it, and so there's systems that come in and repair all that, and there's a system that surveys it for errors, or multiple systems, and then it's